Good morning. Welcome to one more session from our clinical epidemiology unit in CMC Vellore. As part of our short course in clinical epi. This morning, we have Dr. Elbin Peter. He's one of our junior consultants in medicine unit 2 and CEU. He's going to take us through a session on Tripod+Ai. So if you're looking at long-term outcomes of patients, like in a cohort study, and then you're trying to predict what happens to them. So if you want to do a good prediction model, there is a set of guidelines called Tripod. And Elbin will now take us to an extension of the Tripod called Tripod+Ai. Elbin will explain why we need Tripod+Ai. So without any further ado, over to Elbin.
Good morning, everyone. So today, as Sir mentioned, I'll be going on to the Tripod+Ai reporting guidelines. So during the last few weeks, we had looked at multiple checklists which we can use when we do a study on study using an AI-based technique. So we had already covered Study AI and Consort AI. And today I'll be talking about Tripod+Ai, which deals with studies developing and validating a prediction model using regression or AI-based methods. So the Tripod 2015 guidelines was come in 2015, where we generally use Tripod 2015 guidelines for a normal cohort study when we are looking at a normal prediction model using a regression modeling. So now, after 2015, there have been so many models which had come out which uses AI into developing a prediction model. So the usual conventional model was not adequate for the reporting guidelines which was required. So that's why this new 27 item checklist which had come in, and it was reported or published finally in 2024 as Tripod+Ai reporting guidelines. So I'll be going through each item in the checklist, and then I'll be trying to explain how you should be looking at a study which is used in AI for developing a prediction model. So when to use Tripod versus Tripod+Ai? So like I mentioned, if it's a classical statistical prediction model on a cohort study, which uses logistic regression, linear Cox regression and all, use the conventional Tripod checklist. However, if it has got an AI incorporation into it, that is, the AI model is used for predicting the outcomes or this thing, you use a Tripod+Ai checklist. So going on to a case scenario. So in a small mission hospital ICU, many patients with septic shock are dying despite standard medical treatment. And the ICU has limited staffing and equipments, and not all patients can receive intensive monitoring or advanced organ support. So the ICU physician asks, can we identify early which septic shock patients are at higher risk of death, so that we can prioritize our limited resources for those who need them the most? So to answer this question, I've gone through the literature and I've found out a study which deals with this. So this is one study in which they've looked at artificial intelligence-based multi-specialty mortality prediction model for septic shock in a multi-center. And it was a retrospective study which was published in Nature in 2025. So this is the Tripod+Ai checklist, which includes all the 27 items. So I'll be going on to each of the item in the subsequent slides. So the first question is regarding the title, whether the study is identified as developing or evaluating the performance of a multivariate prediction model, and whether they have mentioned about the target population and the outcome. So the study title says it's an artificial intelligence-based mortality prediction model. So they have actually mentioned artificial intelligence. And the target population also, they have mentioned that it is patients with septic shock who is admitted in a multi-center this thing, and the outcome which they wanted to predict was mortality in these patients. So they have clearly mentioned that as the title. The second question is for the abstract. So the original Tripod+Ai checklist says you have to look at the Tripod+Ai abstract checklist, so which I put as a checklist item there, which includes 13 things. So it says that the abstract should be mentioned as in different headings as title, background, objectives, methods, results, discussion, registration. However, they've given us a single paragraph of all these things. And they mentioned most of the things. They mentioned the background, the objectives, methods, results, discussion. But few things which they have not mentioned is they have not finalized the predictors and mentioned in the abstract. And in the results, they have mentioned as area under the curves for internal validation, external validation of the model. However, there was no confidence interval which they have mentioned in the abstract. And they've also not given a registration number. And where is the study being registered is also not being given in the abstract. However, they had mentioned that they wanted to develop a classification fusion model to predict mortality in patients with septic shock, and they had given which group of ICU patients they have taken from what period of time. But these were the things which they had not mentioned in the abstract. Now, the next third question is the background, whether they have given the healthcare context or what is the rationale for developing the model. So they had given the healthcare context. They have given that the septic shock patient's disease is very complex, and currently there is no effective model to predict the prognosis of these septic shock patients. And the coexisting models gives poor performance, and most of them cannot be used in clinical scenarios. So they wanted to construct a robust fusion model. That's their clinical context, which they mentioned. And they've also mentioned the target population, intended purpose, and intended users. So their target population was patients with septic shock in ICUs. And their intended purpose was to design an early warning tool for septic shock mortality risk, facilitating early intervention to reduce mortality, and intended users were ICU physicians. And they've also specified the study objectives, which was to construct a robust fusion model predicting the 28-day risk of death in ICU stroke patients, and to conduct multi-center and cross-specialty validation among various cohorts. So these are the main objectives which they have specified. Now, the fifth question is describe the sources of data separately for development and evaluation sets. So they had taken three cohorts, three central cohorts, which was from multiple centers in China. And it was done as a multi-center retrospective study. And the data involved 4,872 ICU patients. And they've also mentioned the time period in which they have taken these patients. They have taken patients from 2003 to 2023, which was over a period of 20 years. And it is from the electronic medical records of 3 hospitals in China. However, the question also says whether they mentioned the representativeness of the data. That is, which were the people who have taken, from which socioeconomic status or what background was the patients in, and whether they represent the entire population. So this was not clearly mentioned in the study article. They have just mentioned that they've taken the population from the hospital, but whether it involves patients from all SCS strata, which was not clear from their article. Now, participants specify key elements of the study setting. So this, like I mentioned, they have not mentioned what healthcare setting. However, all these hospitals had a intensive care unit. So most probably it would have been at least a secondary care or a tertiary care setting where they would have taken the patients. And describe the eligibility criteria for the study participants. So eligibility criteria in their study was patients with septic shock admitted in ICUs from February 2003 to November 2023, that they have clearly specified. And give details of any treatment received and how they were handled during model development. So as this is a retrospective study, they had not given any specific treatment to these group of people. However, the treatment which these patients received as a part of septic shock treatment, they had taken it as a variable and was used for model development in the study. Now, seventh question is data preparation. Describe any data pre-processing, quality checking from whatever data they had gotten. So they had mentioned an algorithm where they had initially taken around 93 variables as part of the developing the prediction model. So then they have performed multiple processes where initially they deleted 23 variables with high missing rate, which is more than 30%. If the data was not available, they have deleted those variables, and remaining they have looked at agreement of these variables, and variables with more than 90% agreement they have again excluded. Then remaining variables, some of the data were not available, so they have used multiple imputation techniques. And finally, they've used multiple imputation using logistic regression. This is also another method of multiple imputing values and then finally arriving at what value they should use when a value is actually missing. And then out of the 61 variables, they looked at the correlation coefficients, and whichever had a high correlation, they have avoided. And finally, they have arrived at 34 variables, which they had used for model development. So these are the 34 variables finally, which they had arrived at for model development. So they had a clear-cut data pre-processing before they had put these variables into their model actually. Now, eighth question is clearly define the outcome that is being predicted and the time horizon during which they had assessed the outcome. So the outcome was all-cause death, and the time horizon which they had looked at was within 28 days of admission to ICU. That was their final outcome. And does the outcome require any subjective interpretation? So if there was any subjective interpretation, what is the qualification for people who would, or the outcome assessors which they would look at? But this was not a subjective outcome. This was mortality which they've looked at from the retrospective data. So that was not applicable. And whether there was any action to blind the assessment of the outcome. This was also if the outcome was a subjective outcome. So this was not a subjective outcome, so no need of blinding. And it was a retrospective study also. Now, the ninth question is describe the choice of initial predictors. Which were the initial predictors they have taken and whether there was any pre-processing or pre-selection of predictors before model building. So they had mentioned that multiple 93 indices which they've initially taken were included demographics information, disease treatment history, admission information, lab test, medication information. And they've also calculated 4 other variables, which is NLR, neutrophil lymphocyte ratio, platelet ratio, lymphocyte monocyte ratio, and platelet albumin ratio. So all these were the initial predictors which they had taken, and they had a pre-processing also. And they've also mentioned that which were the values, whether they had measured in multiple times. So they have also mentioned that these values were measured multiple times and documented in their records, and they have taken the first measurement for these variables to be selected. Now, regarding the sample size, explain how the study size was arrived at and whether the study size was sufficient to answer their research question. So this was a retrospective study and they have taken this 20 years of data, but they have not clearly mentioned why they had got a sample size of this much or whether this sample size was sufficient enough to build a model which can actually predict their mortality outcomes. That was not clearly mentioned and there was no details about how they had calculated sample size. So they had 3 cohorts of patients. One is cohort 1, which included one of the hospital's patients who were admitted in ICU, and there were 2 other cohorts, which were cohort 2 and 3, which were from 2 different hospitals in China. And then they also had a subgroup cohort from the initial cohort, which was cohort 1 of 1 and 1 second of the first cohort. So in the first cohort, they've used it for training the set as well as an internal validation. And then later on, they've done external validation using other 2 cohorts, which were from different other centers. Missing data, describe how missing data was handled and provide reasons for omitting any data. So like their pre-processing algorithm, which was showed, they'd finally come to this multiple imputation using logistic regression as the imputation method. But before that, they have used multiple imputation models and finally they've arrived at the one which had the higher area under the curve, which was the multiple imputation using logistic regression. So this is just a different sort of methods by which you can imputate the missing data. Now, analytical method, describe how the data was used and did they describe the type of model and how predictors were handled and whether they had given the rationale for model building and model building steps and all that. So like I mentioned, they had 3 central cohorts from the data from the electronic hospital records. And the first cohort was used for developing the model, which had training of the model and internal validation. And they had 2 other cohorts for evaluating the model for external validation. So why did they arrive at 34 predictors? This is because, so finally, after their pre-processing, they have given multiple variables and then they have found out which would give them the better area under the curve. And finally, they've arrived at 34 where they got the better area under the curve. And that's why they thought they would go with 34 predictors to finally use for model building. And this was the model building steps, what they have used actually. So there was initially a training set, which after that, all those data was actually given for internal validation. So internal validation included 7 different models. The details of the model is given down, which is decision tree, random forest, XGBoost, light GBM. So all these are different sort of AI-based models which you can use for training. So the data was given into all these models and the final model was a fusion of all these base models, which is called as the toposis-based classification fusion model. And then they did the internal validation in the data which was available using this TCF model. So in the internal validation, they had mentioned that they had done something called as bootstrapping. So what is bootstrapping? So ideally, when you look at data, so you ideally want the model to work on a population which you want, which is the desired population that you have. So the best method is testing the model multiple times on the actual population and trying and finding out whether the model works and what estimates you would get. But most of the time, this is not practically possible. So you will mostly get a sample which is from the true population, which is your estimated population, which the study had actually used. So you can resample this estimated population multiple times within itself. So in the same sample itself, you can generate multiple different samples with different combinations of the patients. And finally, you would arrive at a final analytical diagram, which is probably similar to the true population. That is what is called as bootstrapping. So they have mentioned this bootstrap sampling technique for internal validation. And they've also done something called as hyperparameter tuning. This is again another type of method which they use before giving the, or before imputing the variables or giving the variables into the model. So before which they had actually grouped different variables, which variables have higher prediction capacity and all that. And that is one of the various ways by which they develop the model. Before developing the model, they use the variables by this methods. So these are the various ways of model development which they've done. And finally, they've given the results as area under the curve, precision, accuracy, sensitivity, specificity, or F1 score. Now describe if any heterogeneity in the estimates of model parameter values was handled and quantified across clusters. So they are not mentioned about any heterogeneity of data across different senders and how was the heterogeneity of the model output and how they had handled across different this thing, and whether they had mentioned whatever plots and for evaluating model performance, what they had done. So the model for performance was given based on these area under the curve and all these scores. ACC is accuracy, PRE is precision, sensitivity, specificity, and F1 score. So, and they have also given the submodels, what is the data analysis, and also the TCF, which is a fusion model. So according to their performance, which they've reported, the TCF model was performing better compared to all the other base models which they have used. And whether there was any model updating or recalibration done after the model which was developed. So this they had not mentioned, but this was a retrospective study. So in the limitation, they had mentioned that there was no model updating or recalibration which was done. Now next is class imbalance. If class imbalance methods were used, state why and how this was done and any methods which they've used for this class imbalance. So they have mentioned that they have used a technique called a synthetic minority oversampling technique. So what class imbalance would mean is, so in this condition, they have looked at patients with septic shock. So when you develop a model, you look at the outcome which you actually want, and then you want to see how much people would the outcome would happen in and how the model can predict that outcome. So here the outcome is mortality. So if you take 100 patients, you might have 10% of the people dying because of septic shock and 90% of the people who will survive. So, but if you give this data to a model, the performance of the model will be lesser or suboptimal because one of the outcome is happening more than the other outcome. So there are multiple ways by which you can actually do this, having this minority sampling. So two methods is, one is undersampling, that when you have majority sampling, which is more and minority is actually less, you can actually undersample the majority and then you can make them somehow equal. Or other ways, actually you have the minority which is less, you can actually oversample the minority and somehow make the final data set to be equal and then feed it to the machine. So the synthetic minority oversampling is an AI somehow oversampling the minority and making them finally an equal group before feeding into the system. So they have done the synthetic minority oversampling technique to the data set before processing. And describe any approaches that were used to assess the model fairness and their rational. So the model fairness, so they did not describe the type of the population or what is what are they representative of, whether they represent all the socioeconomic status and all that. So the model fairness is actually not very clear from their study. Now the model output, specify the output of the prediction model based on probabilities and classification. So they had predicted a probability of 28-day mortality in patients with septic shock, and whether they had given any classification. Classification would mean whether they have classified it further to high risk mortality, low risk mortality, or intermediate risk, which they had not done, and there was no threshold cutoff also they had provided. Now, training versus evaluation, whether there's any differences between development and evaluation data in healthcare setting. So, like I had mentioned, they had different cohort for internal validation and development of the model. And then they had subgroup cohorts for cross-specialty validation, which is pediatric and respiratory medicine ICUs. And they had two other separate cohorts from the Chinese hospital, which was used for external validation. And name the IRB board or ethics committee, and whether they had given informed consent or they had waived off the informed consent. So the ethics committee had waived off the requirement for informed consent as this was a retrospective study, and they've used only the existing data and did not require any other additional patient interventions. And this was the IRB board which had approved their study. Now give the source of funding and role of funders for the present study. So these were the funders which funded the study, and the role of the funders they had not explicitly mentioned in the article. And they did not have any competing interest, and provide registration information for the study, including register name and number, or state whether the study was not registered. So they had mentioned in the study that this was a retrospective study and no public involvement. So they did not prepare any research protocol, and the study was actually not registered. And details of availability of data, they've said that data is not publicly available, but the data could be given upon request of the people, and provide details of the availability of the code. So the code can also be found on that link. Now, patient public involvement. So there was no public involvement in the study, which they've reported. Now, describe the flow of participants through the study. So they had given a flow of participants based on this diagram. So like I had mentioned, there was one cohort which was used for internal validation. And then there was two sub cohorts using, and they had done cross specialty validation. And then they had an external validation with two separate other cohorts. And whether they have given the characteristics of the study population as a whole. So they had given the baseline characteristics of the study population in the training set internal validation and multiple sub cohorts as well as the external validation cohort. They had given it in their article. Now, model development, specify the number of participants and outcome analysis. So I'll come to that. Before that, did they give full details of the prediction model? So the details of the prediction model was a toposis-based classification fusion model, which combined the 7 models which they've used as base models. And the code is available, and restrictions to use, they have mentioned that it is not publicly available. And regarding the outcome events in each analysis, so these are the ROC curves they have plotted, and gives the outcome of each analysis. So this first one is the internal validation curve which they given. So like you can see that in this, the area under the curve is more for the TCF model, which is 0.733. So ideally in an ROC curve, the best value would have been 1, which is not practically possible. However, compared to other models which have looked at, TCF model seems to be performing better than the other models in the internal validation cohort. So now they have given the data for the internal validation in the other sub specialties as well, which is the pediatric ICU and respiratory medicine ICU. In that also the TCF model seems to be performing well, which is 0.808 in the pediatric ICU cohort, but respiratory cohort, it seems to be performing a bit lesser, which is 0.662. But in the multi-specialty or multiple center data, you can find that the AUC curve which they've got is 0.78 and 0.78 in both the cohorts, which seems to be performing well when they've done the external validation also. Now, whether they have reported any results of any heterogeneity in the model performance across clusters. So in the multiple centers which they have done, they did not have heterogeneity because both the AUCs are similar, and they did not report about any of the heterogeneity in their article also. and whether there was any reporting results of any model updating or updating of the model. So that model updating details was not reported. So they've also given something called as calibration curve. So here the ROC curve is something which you plot between the true positives and false positives. And then the maximum value is 1, which you should get, which is ideal, or which would mean the best performance. Calibration curve is something which you plot based on, so this predicted probability is what the machine actually predicts the probability of death is. And this actual probability is actually what is the probability of that patient dying, or that is based on what result they've got. So the best scenario would have been this diagonal line, where the machine also predicts a 0.2 or 20% risk of mortality, and the machine, and the actual mortality risk is also 20%. So then based on the TCF model, this is the graph which they have got. So what you can see is when the predicted probability by the machine is actually lesser, actually more, which is 0.2, the actual probability is actually lesser, which is somewhere between maybe 0.1 or something. So in the lower probabilities, the machine or the model is actually overestimating that. It is saying that the probability is 20%, but actual probability is actually somewhere around 10%. And somewhere in the middle, it seems to be coinciding with the best scenario. And if you can see at high probabilities, like at 0.8, when you can see that the machine is predicting the probability as 0.8, where the actual probability is somewhere around 0.9. So there actually the model is actually underestimating the final probability. So most of the models, when they develop, this is the type of curve that they would get. At lower and higher probabilities, it might not be performing well, but somewhere in between they'll be performing well. So that's what the calibration curve which they have got. Now, interpretation of the results, given overall interpretation of the main results. So their interpretation is the model achieved consistent and good performance on both internal and external validation set, and outperform the individual models in predicting the 28-day risk of death in septic shock patients. And whether they have, thing is, one of the objectives which they had mentioned is this will be a ready-to-use tool for physicians, but that might not have been met here because it was a retrospective study and they've not given the code and all that. That was not clearly met. And whether they've discussed any limitations of the study. So limitation they've mentioned, their limitations were retrospective study design, and they have said that they need a prospective design to evaluate clinical efficacy. And data is derived from a limited number of centers, which may limit the generalizability. And they had used 34 variables. So whether the best could have been having a smaller number of predictive variables, which could be more user friendly. And they wanted the model validation cohort having limited positive events. The number of deaths were very less. So which could affect the performance of the model, even though they had done multiple methods to increase the performance also, the events were actually lesser. And then specify whether they have mentioned anything for the future research. So for the future research also, they have mentioned that to increase the generalizability, you can do future research. You can do future research for integrating additional data modalities and conduct prospective studies for evaluating the clinical efficacy. So they had given future research plans as well. So finally, I've completed all the checklists. So this is what have been mentioned in their study article in the supplementary appendix that they have actually followed. So they have actually ticked everything that they have followed based on the tripod checklist. But based on our analysis, so there were few things that in the abstract was not complete, and sample size arrival was not mentioned, and heterogeneity they had not mentioned, and there was no approaches for assessing the model fairness. And there was no results of model updating, and there was different healthcare setting they had not mentioned. So there were some flaws in how they had reported, but overall, it seems to be that they had followed most of the guidelines of how it should have been reported. So back to my case scenario. So this is an ICU physician in a mission hospital wanting to find out whether how can you assess mortality risk for their septic shock patients. So in this study, the model development is fairly well done and can recommend to the ICU physician. It's a good model. Given the cost we can probably incorporate into the hospital settings, and also it is readily usable. But the ICU physicians wanted it to decide, because they had limited resources, they wanted to see which patient should they reinvest their resources to, or take the ventilator from one patient and give it to another patient. But that I would not use the study because that I would still use the clinical judgment to decide whether that can be done or maybe not based on this model. Okay, thank you. I would like to acknowledge Dr. THAMBU sir and Vignesh sir for helping me making this presentation. Thank you.